Thank you, chairs, my dear delegates, participants, and my co-speakers. Good afternoon. I'm going to talk on how to improve the surgical technique of trabeculectomy. I do not have any financial disclosure. Well, if we look to this slide, you will see the glaucoma surgery has been a paradigm shift. The traditional surgery, trabeculectomy and tube shunt is less, but we can find dozens of glaucoma surgery that is called minimally invasive glaucoma surgery, including eye stent, hydras, infocus, Zen, etc. But if we look to a study recently done, published in Ophthalmology, a primary TVT study with 3 years follow-up, what we see? We see the trabeculectomy is still the gold standard for the glaucoma surgery and 72%. And it's very especially important for us in this Asia Pacific region because we deal with the very advanced glaucoma cases where this trabeculectomy and tube is really important to do and how to do very successfully that can give us better result. Now, in my opinion, trabeculectomy is not a day surgery. Rather, it's a package of 1 month. Because I tell preoperative, you have to prepare the patient for about 1 or 2 weeks. Even after surgery, you have to do different titration, like massaging, releasable suture releasing, or argumental suture lysis, so we can make our success for a long time. So we get this patient frequently. The patient comes with ocular surface disorder. So we must address with tear substitute and sometimes with short course of steroid. Patient comes with blood thinners, taking PG analogs, cholinergic. We must stop these drugs and use oral acrylamide if possible. If the pressure is very high, if it is more than 35, we must use intravenous mannitol or other IOP-reducing agents. In recent studies showing that peripheral anesthesia may cause optic nerve blood flow reducing. So it is better to avoid the peripheral anesthesia. Rather, we can try to do surface anesthesia or with the very low amount of subcutaneous anesthesia. Of course, in some cases where the children, metadata patient cannot cooperate, we can do peripulvar or general anesthesia. Well, in some cases, we do not need to give any globe fixation because the patient can look down. The patients are cooperative. But if the patient is not cooperative, definitely we can use some traction sutures, especially the corneal traction sutures. I use 60 Vicryl or 60 silk or even 80 Vicryl for this purpose. I do not encourage to use the superrectus brittle sutures that may produce some hemorrhage and some fibrosis. In almost all of my cases, I use the low concentration mitomycin subtenos. I use 0.3 per milligram concentration. I take 0.1 ml from here and 0.1 ml lignocaine from here. So it becomes low concentration. I give it subtenons in the peripheral part of the fornix, the peripheral of the conjunctiva, the subtenon area. And after a few minutes, the massaging with the squint hook or other soaked swab stick, we can just diffuse it. Then after a few minutes, you can do the surgery. Regarding fornix-based peritomy, I usually make the fornix-based because in many studies, it has shown there's no much difference of the fornix-based or limbal-based peritomy. In most of the cases, I do fornix-based peritomy, and I do the 2 layers, first the conjunctival layer, and then the tenos layer. And this way, I get my surgical field is very clean. Then with low temperature cautery, with some small amount of cautery, I do far dissection also. Because if you do not do the dissection in the far area, in the deeper part, that may produce a ring of steel that which can actually fail the trabeculectomy. Now, the very important part is the making the flap of my trab. Usually for the open angle glaucoma, I make half thickness, usually quadrangular, but sometimes triangular. And you can see, I can see crescent blade here. This is very important to see the crescent blade. That rule of thumb is the half thickness of the flap. I go up to 1 millimeter to the limbus, not up to the limbus. And I go dissection up to 1 to 1.5 millimeter in the clear cornea, the peripheral cornea. Then I make a side port, steps a little bit aqueous, so antechamber pressure becomes less. Then I use the Kelly's pass forceps to excise the peripheral cornea and the trabecular tissue, and then peripheral broad-based iridectomy like this. Next part is the angle closure glaucoma. Protocol a little bit different. I do a thicker superficial flap in angle closure glaucoma cases. I make tighter closure of the scleral flap, use of releasable sutures, and antechamber should be formed by BSS or air. So if you see in a post-acute congestive glaucoma cases, I'm putting the sub-tenons MMC, then some tenons lignocaine, I'm making the flap. And you see here, if you notice here, I'm making the flap a little thicker. How do I know it is thicker? I cannot see clearly. The Christian I cannot see clearly. So this is one of the way you can understand it's a little bit thicker. Other steps are almost same. Now, there is another way to make the excision with deeper flap excision. And if we make a deeper flap excision, like non-penetrative deep sclerectomy, we can make a aqueous lake here. And that actually decreases the failure and increases the success rate. And in a study, recent study published in Journal of Glaucoma by Dr. Tanuj Dada et al., found that limited deep sclerectomy has a better success rate. So in my experience also, I find if I need low target pressure, I usually do excise the deeper flap, and I get even sometimes single-digit intraocular pressure. Now, closing of the scleral flap by suture, usually I use 10O nylon. I make two sutures in the two corners, almost in most of my cases. And this suture is such a way that about same distance, distance. And why I do it? Because I find astigmatic correction is very less induced astigmatism. So if you can make very good suturing, this patient can take even the premium IOL in future. This is very important. And of course, in every case, I bury the suture, because if you do not bury the suture, the patient might have irritation and might have some problem. In some cases, yes, we cannot use the MMC. Definitely, you can use the releasable suture in every cases. And also you can, especially in pregnancy, in small children, young children, even in very thin sclera, in high myopic cases, you can of course do releasable suture. Where the argon-loser suture is not available, this is the only way they can help. And sometimes you can use the collagen matrix. It also helps in some cases where vitamin C cannot be used. Even in some cases, where people started using vitamin C and collagen matrix, that also giving good result. Well, I want to give some important here. The vascular endothelial growth factor is important for the old healing pathway. So if we can use anti-VEGF drugs like Avastin, what happened? So I have used more than 200 cases in my study, and I found that in the two group, one is the MMC group, another is the MMC with Avastin group. In MMC group, I found 76% patient did not need any IOP lowering agent. On the other hand, in the MMC and bevacizumab group, 88% patient did not need IOP lowering agents postoperatively. So definitely, this success rate is higher in the group where bevacizumab or anti-VEGF was used. And Dr. Malik Kahuk and other authors already supported the same concept that anti-VEGF really helps to decrease the intraocular pressure. Finally, the tenons capsule and the conjunctival approaching and suturing, I think it is very important. And I have published one of the report on this, that horizontal mattress suture, continuous mattress suture is really important to make a watertight suture. I give suture from one corner to another corner by same 8O Vicryl from one corner to another corner, so that I get a very good watertight suture in almost all my cases. So usually I take some time to do this, but I do it and I find it is really important for the watertight sutures. And finally, you can see here, I'm putting some fluid and there is patency can be tested also here. So friends, in summary, I would say the preoperative preparation is really mandatory for a successful trabeculectomy. Peripheral anesthesia is to be avoided when possible. Proper use of anti-fibrotic agent and anti-vascular endothelial growth factor agent is useful to make trabeculectomy safe and more successful. Of course, the agents depends on the indications and surgeon's choice. Thank you so much.